Hello, this is Dr. Francis recording the video for acute and chronic kidney injury. The PowerPoint is located in shared files. The anatomy and physics, the basic unit of the kidney is the nephron, and 4 functional regions are included: the glomerulus, the proximal convoluted tubular, the loop of Henle, and the distal tubes. The physiology that occurs is filtration occurs at the glomerulus, which is otherwise known as your GFR, your glomerulus filtration rate. And that's how they determine what level of kidney disease you're in. Reabsorption is 99% water, your electrolytes, and your nutrients undergo reabsorption at this point. When the kidney is not working, that is what can cause the electrolyte imbalance. And also the lack of reabsorption of some of the nutrients can cause have some difficulties with calcium absorption, which can lead to bone disease. The active tubular secretion is the proximal convoluted tubes. This is a little bit of a complicated slide, but it basically outlines where the filtration occurs. As you can see, as it travels along the nephron, there's a reabsorption of the uric acid and the organic acid. When the kidney is not working, then that uric acid is allowed to stay within the bloodstream, and that's the toxin that can be built up. As you go into the loop, that's where the disbursement of water can occur. That's why when we utilize diuretics, it is in that loop of Henle that the diuretic is most effective. As we travel up the proximal, there is a removal of water also and some sodium chloride. At that point, aldosterone, if needed, if the blood pressure was low, would also could be reabsorbed in order to maintain a better blood pressure. Then as it travels through, then the uric acid is made into urine and it can leave the body. If there is a malfunctioning of the kidney, then this does not occur and the uric acid and the toxins stay in the bloodstream and they will be detrimental to the person. When the kidneys fail, less waste is removed and it remains in the blood. There's inability to regulate your fluid, your electrolyte, and your pH balance. Kidney disease can occur either acutely, which is usually due to lack of volume, or if it is sustained due to comorbidities of hypertension and diabetes or polycystic disease, then it can become chronic. One of the things that you see is a nitrogen compound buildup in your blood, and that's why there is that rise in the BUN. Once actual kidney damage occurs, then there's a rise in the creatinine. The actual kidney injuries that can occur, it can be to the kidney itself, intrinsic damage, or it can be pre-renal. Pre-renal refers to the amount of blood flow that is going into the kidney, or post-renal, so the nephron in and of itself is working. However, there's a complication with the outflow. Could be due to BPH, benign prostatic hypertrophy, or it could also be due to a kidney stone. So pre-renal is about volume, that there has not been enough volume to the kidney, and it's what it leads to is ineffective renal perfusion. Intrarenal is actual damage to the renal parenchyma, or the tissue in and of itself, and that if it is sustained nephrotoxins or hypovolemia, it can lead to ATN, acute tubular necrosis. There's 4 clinical phases associated with that. Pre-renal and intrarenal make up 80 to 95% of acute kidney injury. Pre-renal, there's a reduction in the GFR. If you remember from lecture, when the GFR reduces, that's how we determine what stage of kidney disease you're in. The reduction in the blood flow, either due to volume or perhaps cardiac disease, leads to pre-renal AKI. Why could we possibly have a reduction, hemorrhage, volume depletion, excessive diuresis? We could have the volume, but the heart might not be functioning well, cardiac failure, cardiogenic shock, and other things that we could do to injure the kidney, such as long-standing NSAIDs or diagnostic agents such as contrast dye. The pre-renal injury is your most common form of acute kidney injury, and it's related to the decrease in blood flow. The kidney should receive about 22% of the cardiac output in order to regulate the fluid and the lights. When the renal blood flow decreases, there's a decrease in the GFR. When blood flow decreases about 25% of normal, then we can have an ischemic change to the kidney. The tubular epithelial cells are most vulnerable, so they will start to shed if they are hypoperfused. And that's where we have the tubular necroses occur. The causes of pre-renal is depletion of some way of the vascular volume, either due to hemorrhage or loss of NG drainage, burn patients, impaired perfusion due to heart failure, decrease in vascular filling, which occurs when we have massive vasodilation that is seen in sepsis and anaphylaxis. The diagnostic agents and vasoactive mediators stimulate the intrarenal vasoconstriction, and we have hyperperfusion. High-dose dopamine contrast agents. What about the elderly patient? Why are they so at risk? Well, as you know, the elderly patient is already slightly dehydrated, and their kidneys are slightly hyperperfused. So any small insult at all to them can lead to renal damage. In a state of renal hypoperfusion, angiotensin II, a potent renal vasoconstrictor, constricts the efferent arterioles of the kidney as a means to try to preserve the GFR. ACE inhibitors and ARBs reduce the effect of the angiotensin on the blood flow, and they decrease that intraglomerular pressure. This provides protection properties in patients with hypertension and diabetes. As you know, patients with hypertension and diabetes are the most at risk for renal disease. However, when combined with diuretics, this may cause some pre-renal injury because it could deplete some of the volume and therefore kind of exacerbate some pre-existing kidney disease. NSAIDs decrease renal blood flow by inhibiting the synthesis of prostaglandins, and they can, in long-standing, be nephrotoxic. The signs of pre-renal injury that we most is the classic is the elevation of the BUN and creatinine. In post-renal, it's the obstruction of urine from the kidney, either due to a stone, a calculi, a stricture, which just means the ureter has kind of collapsed upon itself, a bladder tumor, or urethral obstruction, prostatic hyperplasia, otherwise known as BPH. What is the measure that we use to fix a post-renal injury is you treat the underlying problem. You remove the stone, you try to reduce the BPH in order to have a better outcome. Causes for the post-renal is that the urine is made and then isn't able to travel through the ureters or out the kidney. So it could possibly be a kidney stone, obstructed ureter catheter, a bladder stone, or bladder, urethra, or renal malignancy. Acute tubular necrosis is damage to the kidney, to the tubes or the glomerulus or the interstitium, which is the tissue in and of itself. The cause is typically due to ischemia from pre-renal injury from hypoperfusion. The kidney has been insulted from lack of blood flow. Other causes of injury to the tubular structure of the nephron are intratubular obstruction. There's been some collapse within the nephron that doesn't allow for perfusion, either inflammation or some type of damage associated with that. It can be ischemic or toxic in origin, and the destruction of the tubular epithelial cells is what causes the suppression of the renal function. Tubular epithelial cells are really sensitive to ischemia and toxins. Once they are damaged, they're inflamed, and then they are they are not capable of performing the function of filtration. The tubular injury of the ATN is absolutely reversible if it is caught in time. If it is noted that they are having a less urine output, we're able to bolus and reperfuse the kidney, then the kidney can be saved. What causes or what is at risk for ATN is in persons with major surgery, severe hypovolemia, or sepsis. As you know, in sepsis, it's the massive vasodilation that occurs out in the periphery. Many drugs are nephrotoxic. They can cause renal vasoconstriction. They can cause damage directly to the tubes or intratubular obstruction. One of the greatest nephrotoxic agents is aminoglycoside, vancomycin. Kidneys need a rich blood supply and a great ability to concentrate toxins at a high level. If you need to give a contrast dye study or you need to give vanco to someone with renal insufficiency, you have to make sure that you perfuse the kidney well. It is also a place of metabolic processes where harmless agents can be turned into toxic metabolites. Kidneys are sensitive to nephrotoxic injury. The pharmacological agents are aminoglycosides, cancer drugs, NSAIDs, and contrast dye. Factors that contribute to aminoglycoside nephrotoxicity is if already there was a pre-existing kidney disease. And in addition to that, the patient is slightly dry or hypovolemic, or there's concurrent administration of other drugs that are also nephrotoxic. Perhaps they're giving NSAIDs along with the vancomycin. Radiocontrast dye is also nephrotoxic and has a direct hit onto the tubulars. ATN from intratubular obstruction is usually or generally due to a buildup of uric acid, as you can see with gout, or with myoglobin, which could be released from injured muscle or hemoglobin. Rhabdo is myoglobin that acts as hemoglobin in oxygen reservoir in muscle fibers. Myoglobin, once it's leaked into circulation, has a very low molecular weight and is filtered into the glomulars and is very, very nephrotoxic. So it occurs in stages. Initially with ATN, there's an initial phase which can last hours or days, and then there's a maintenance phase where now the patient begins to be allogloric, and they're a better outcome for the non-allogloric phase where they are still making urine. The conversion from non-allogoria to allogoria is a marked decrease in the GFR. As your GFR drops, that's how you know more renal damage has occurred. When there is less GFR, then there is more retention of waste and more retention of fluid that could cause some edema or pulmonary congestion. If oliguria is prolonged, we will have an increase in hypertension with a uremic syndrome, which can lead to seizure, coma, and somnolence. Prevention and early detection is key. Pre-existing renal insufficiency and diabetes, particularly at risk due to drugs such as NSAIDs, can really markedly injure the kidneys. The key thing, of course, is to monitor their urine output. It should be at least 30 mLs an hour. You're also looking at the color of the urine output. Early manifestation of tubular damage is the inability to concentrate urine. So initially, you might see a great deal of urine output. Tubular damage manifestation can cause a leakage of protein, so they have proteinuria, hemogloria, myeloglobia, casts, and crystals in the urine. That just means that there is no filtration occurring and everything is being released into the urine. BUN and creatinine regarding the ability to remove the nitrous and waste from the blood. The main issue is and always will be to identify the cause. If you can identify what is causing the damage, then you can eliminate that. And of course, to discontinue any nephrotoxic agents. The diagnostic measure, the gold standard, we typically know that the kidney is in trouble by the BUN and creatinine. The gold standard of how much damage has been done is the GFR. GFR of less than 60 means loss of half or more of normal adult kidney function. Your GFR at a baseline should be about 120. So if we're less than 60, then only half of the kidney is doing its job. GFR estimates using serum creatinine. There is a formula that can be utilized, but most UA will calculate your GFR for you. You saw this in class today when we were talking about chronic, where it's scaled from stage 1 through stage 5. Stage 1, meaning there's very, very minor insult. The GFR is still at 90. At stage 5, it can be less than 15, and dialysis is needed. The clinical manifestations of chronic. So we have gone through the acute, which is reversible, into chronic. In chronic kidney disease, there's elevated levels of nitrogen waste. Azotemia is the earliest sign of kidney failure. Urea, one of the first nitrogen waste products to accumulate in the blood. Uremia is the accumulation of nitrogen waste products. Progressive kidney disorders leads to electrolyte imbalances, hyperkalemia, acid-base imbalance. The buffer is not being bicarb is not being able to be released from the kidney, so it could leave the body in a pervasive state of acidosis. Cardiovascular malfunctioning and drug elimination. The fluid and sodium and water balance, the kidneys regulate your extracellular fluid volume. As renal function declines, the ability to regulate the sodium excretion decreases. In addition, potassium is excreted through the kidneys. When the kidney is not functioning well, you go into a state of hyperkalemia. The acid-base balance, the pH, the kidneys are responsible for regenerating the bicarb. So when there is a deficient amount of bicarb, there it allows the hydrogen ion to dominate, and we are in a state of acidosis. Classic buffers, it fails to the retained acid. So in addition to the state of acidosis, bone demineralization also occurs. So the patient can be in a state of osteoporosis, which causes a bone weakening and also release of calcium. So the patient can also have a high calcium level, hypercalcemia. The complications that are associated with chronic kidney disease is individuals will die unless they have some form of dialysis. We talked about the hemodialysis and the peritoneal dialysis. A coexisting condition that contributes to kidney disease is dyslipidemia, which means there's a high lipid level within the vessel, which further impedes the blood flow. Hypertension can result. There's an increase in vascular volume, an increase in their PVR, peripheral vascular resistance, so the blood flow is diminished. Decreased renal vasodilator prostaglandin level. The prostaglandin is your protective agent upon the nephron. Increased renin, angiotensin, aldosterone system. Bone disease is one of the hallmarks of chronic kidney disease. There is osteoblasts are produced in excessive amounts of bone, but the demineralization fails to keep pace. There's leakage and the bones get weak. Thereby, they are at risk for spontaneous skeletal fractures due to the loss of their bone mass. Early treatment of hyperphosphatemia and hypocalcemia. We have an elevated phosphate level and a low calcium level. Helps to prevent some of the problems with the skeletal system. The drug that we can give to lower the phosphate level is felvomir. Anemia. We talked about today how the kidneys do not manufacture the hemoglobin, but actually send the hormone erythropoietin to the bone marrow to have the bone marrow produce the hemoglobin. In the absence of that, the chronic kidney patient is in a persistent state of anemia, and then in that persistent state of anemia, there's less oxygen carrying capacity. So there could be a risk for diminished perfusion of oxygen throughout. Some of the things they do is they give iron supplementation to make the hemoglobin stronger and recombinant human erythropoietin or epigen to stimulate the bone marrow. The treatment is conservative medical management. Measures to reduce the deterioration of renal function is if there is any UTI, it's treated promptly. Avoid the use of nephrotoxic agents, good blood pressure control, good glucose control, and smoking cessation. The dietary management that is associated with renal disease is protein is restricted. Protein breaks down into nitrogen waste, and we already have a buildup of BUN. High protein diet is high in phosphate and acid, and we want to diminish the amount of phosphate and acid. Other sources of energy should be carbs and fat. Sodium and fluid restriction, so there is not a retention of volume that could also increase your blood pressure. Chronic kidney disease from tubular disease leads to salt wasting. End stage chronic kidney disease, there's also restriction of potassium. And the reason for that is they are in a state of hyperkalemia. They advise or recommend limiting foods with high phosphates, such as processed foods, spreadable cheeses, puddings, and baked goods. When you look at a schematic of what occurs during chronic kidney disease, there's an alteration in their salt and water balance, which could lead to hypertension. There's an alteration in potassium, hyperkalemia. There's a diminished ability to eliminate nitrogen waste, which leads to uremia, which could lead to pericarditis. Also causes some problems with coagulation, which could cause bleeding. There's a diminished production of erythropoietin, so the bone marrow is not stimulated to make hemoglobin. They are anemic. We know that they lack the ability to produce the bicarb, so they are in a persistent state of acidosis. Due to that, there's also skeletal loss of calcium and weakening, and they have problems or softening of their bone, cause osteodystrophies, which is just a fancy way of saying that their bones are softer and more susceptible to breaking. Activation of vitamin D is diminished, so that leads to a low calcium level, and there's inability to eliminate the phosphate, which leads to an elevation in the phosphate level, which also contributes to the low calcium level. All of this can lead to impairment of their immune system, which makes them very susceptible to illness. Skin disorders, GI issues, neurological, once you have a buildup of all of these toxins, travels to the brain, and it makes the brain very confused, and sexual dysfunction. Chronic kidney disease, the manifestations, one of the things we do see is the buildup of urea and acidemia, which increases the creatinine and the BUN. Altered fluid and electrolytes, as well as acid base. There's salt wasting, acidosis, and hyperkalemia. Cardiovascular complications are hypertension and heart disease, and your GI disorders are anorexia, nausea, vomiting, and formation of ulcers. The mineral metabolism disorders are metastatic calcification and bone disease. the hyperphosphatemia, and the hypocalcemia increase the PTH, calcium reabsorption from the bone, and we have bone loss. The bones are weaker. Decreased vitamin D activation also increased PTH, impairs the osteoblasts. Your cardiovascular complications are the anemia. Once we have anemia, we have less oxygen carrying capacity, and that is due to the decrease in their erythropoietin. So there's weakness, depression, insomnia. Their blood gets a little bit thicker, which means an increase in viscosity, which causes the heart to work a little bit more. There's an increase in the heart rate, which could cause, there's an increase in the heart rate and less perfusion, which can cause angina pectoris. The heart begins to have aches and other ischemia. There's a decrease in the formation of platelets, coupled with the fact that they typically need some type of anticoagulation for their port, which would increase the potential for bleeding. Chronic kidney disease manifestation is a decreased inflammation and immunity, which makes them susceptible to infection. They have alterations in their central nervous system as well as their peripheral. There's some peripheral neuropathy, restless leg, and uremic encephalopathy. The uremia can travel to the brain and cause confusion. Sexual dysfunction, impotence, hypofertility, and dysmenorrhea. Their skin disorders are dryness, bruising, and terry nails. That is it for the review for the acute kidney injury and chronic kidney injury. I will be on campus. If you have any questions after listening to the video, stop by and I will be happy to answer them for you.